Thanks, Colette. Hello, everyone. Thanks for this brilliant opportunity to present a programme of research that I'm building, I suppose, trying to demonstrate the impact that behavioural science can have in terms of improving health outcomes. I'm not quite sure whether Mike Kelly's was an introduction, or I think that the point that I've decided to take from it in terms of looking at behavioural science, and I do happen to know that many of Mike's collaborators are behavioural scientists, is that behaviour change isn't easy, and I think there is a lot that behavioural science can bring to the story. So what I'm going to do in the next few minutes is talk about behaviour and health, what do we know about behaviour change, why don't we know more, and how potentially we can do this stuff better, and I'll give you a little snapshot of some of the work that we're currently conducting within the Health Behaviour Change Research Group. So this audience probably doesn't need much by way of introduction as to the relationship between behaviour and health and the potential impact that behaviour and successful behaviour change can have in health. And really there are three ways in which I see this relationship existing. The first is behaviour to promote health, so our leading causes of morbidity and mortality, circulatory disorders, cancers, respiratory disorders, have in the main behavioural predictors and determinants. Behaviour is key to managing chronic illness, and our recent policy document on tackling chronic illness emphasises the centrality of behaviour change. So, for example, an individual diagnosed with diabetes has to, on a regular basis, monitor their blood glucose levels and change their medications, exercise and diet as a result of what they're monitoring. And finally, and this is related, I suppose, to the translation of research and evidence findings, and this is really where we're looking at the key aim of changing health professionals' behaviour to implement best practice and clinical guidelines. So what do we know about behaviour change? There were NICE guidelines, UK NICE guidelines produced in 2014, and if you are interested in this area, I would really recommend you have a look at these guidelines, which I think are really excellent. In a nutshell, what they're really suggesting is that we need to plan and evaluate interventions carefully, taking account of context, using evidence-based strategies, describing the mechanisms of change and using theory. We need to train all the relevant practitioners in evidence-based behaviour change skills and competencies. And what we know about effective interventions is that those interventions that target multiple levels, that's individual, community and population, are more likely to be effective. And effective behaviour change strategies at an individual level, which have been shown across the board, include planning and goal setting, feedback and monitoring, using social support, increasing motivation and promoting a structured follow-up. So there are some examples of effective behaviour change interventions, and this is one that was funded back in 2004 by the Health Research Board, a large randomised controlled trial in primary care that Andrew Murphy led, called the SPHERE study. And in this study we developed and tested an intervention to promote secondary prevention of coronary heart disease delivered in general practice. And we managed to impact, in terms of the intervention group, reported at 18-month follow-up, reduced hospital admissions compared to the control group. Another really nice example, not from our group but from a Scottish group, is this FIT trial, in which they have demonstrated that among middle-aged men who participated in a weight loss intervention programme delivered through the Scottish Premier League football clubs, they successfully demonstrated significant weight loss. But I suppose, and maybe this was Mike Kelly's point as well, is that for every successful intervention, there are multiple unsuccessful interventions. I've certainly been involved in some of them, and maybe you in the audience have as well. So why don't we know more? I think that the problem really is that there are multiple reasons why we don't know more. Very often in our behavioural interventions, we're measuring the wrong outcomes. We're not measuring behavioural outcomes. It's very often not clear what our interventions are. If we were really kind of pinned to the wall and said, what exactly is in your intervention, some of us would struggle to describe the exact content of our interventions. And very often our interventions are not based on existing evidence, they're not developed in a systematic way. And if they do work, very often we don't know why or how they work, and even worse, if they don't work, we don't know why they haven't worked. So some of you might be familiar with this principle, which I suggest is one of the most commonly used principles to design interventions. Are any of you familiar with this? So So this is basically, it seemed like a good idea at the time, and this is very frequently, and I've certainly been involved in research groups where members of the research team are very convinced that they know which intervention is going to be successful. So very often this is what our studies look like. We start with a health problem, maybe high levels of blood pressure. We develop a complex intervention. We're not exactly sure what's happening in there. And we're measuring clinical outcomes, which either change or don't. And very often we struggle to interpret the meaning of our results, and it's very often very far from a eureka moment. So, how can we do this stuff better? And I suppose this is where I'm coming, that behavioural science has much to offer in this area. So this young man, Molly Byrne, I think coined a really good definition of a psychologist or a behavioural scientist. Someone who can make other people do things they don't want to do. So when he manages to get his sister to change over the TV channel, he says, yes, I'm a psychologist. But as you can see, maybe some of his strategies might not quite get ethical approval. But I think behavioural scientists are advocating that interventions need to measure behavioural outcomes and judge their effectiveness in terms of their effectiveness in changing behavioural outcomes. Interventions need to be clearly described, and I'll talk in a minute about some tools that we have now providing a methodology to clearly describe our interventions using behaviour change techniques, a very specific language to describe interventions. And interventions need to be theory-based and developed in very systematic ways, accounting for the mechanisms of change so that we do have an understanding of why our interventions work. So this is the kind of stuff we're trying to do in the Health Behaviour Change Research Group. And as Colette said, this research group was formed in January 2014, supported by a HRB Research Leadership Award. And at the Health Behaviour Change Research Group, really what we're aiming to do is to improve population health by applying behavioural science. So we want to lead the behavioural science and research agenda. Our bread and butter work is developing, piloting and evaluating behavioural interventions. We want to advance the science in this area, and critically we want to develop capacity and build capacity among behavioural scientists, but more broadly among lots of interdisciplinary teams. We're doing this with an advisory board which includes our health partners, the Diabetes Clinical Care Programme and the HSE Health and Wellbeing Programme, and international scientific advisors, including Susan Mickey in UCL and David French in the University of Manchester. So very briefly, two tools that we're using. Some of you may be familiar with these. The Behaviour Change Wheel provides a very accessible and systematic approach to develop interventions, moving in that central spoke, and maybe you can't really see it very well, but that central spoke of the COMBI model, in which we look at the capability, opportunity and motivation factors which explain and predict behaviour and behaviour change. And these guide us in terms of systematically selecting which types of interventions and which types of intervention techniques we choose for our interventions. And then I mentioned briefly before the behaviour change technique taxonomy, which I think is an invaluable tool for clearly describing what are the content of our interventions. So there's 93 behaviour change techniques organised here into 20 different categories. So very briefly, I'll show how we've applied this to one particular intervention in which we were looking at promoting the delivery of sexual counselling in cardiac rehab. And we have developed and are currently piloting the CHARMS intervention. So the baseline to this study was that we demonstrated that sexual problems were twice as high in a cardiac sample as in the general population. This would be, these were Irish data, but replicate international findings. Guidelines exist suggesting that all patients should receive these guidelines in cardiac rehab. However, there's very little evidence, in fact no high quality evidence, about how best to get cardiac rehab staff to deliver these kinds of interventions. But we do know that patients very, very rarely receive any kind of sexual counselling or support in this area, and they do want it. So we use the COMBI model, looking at capability, opportunity and motivation, to try and understand and get a better sense of why health professionals were not delivering services in this area. And then we work through a systematic approach, moving from the COM-B factors, so things like if the staff reported that they'd low confidence in their ability and their skills to deliver these types of interventions, and we selected intervention functions and behaviour change techniques as a result of that. So you don't need to go into the detail here, I just want you to get a flavour of the systematic approach that we've used. And hopefully our final CHARMS intervention, which as I said is being piloted in 2 hospital centres currently, is, I believe, more likely to be effective because we have used these systematic approaches, and I think will advance the science in terms of being able to respond to what we find in the trial. So we're using these types of systematic methods and approaches throughout a whole range of areas, for example, looking at hand hygiene practice in hospitals, looking at medication adherence, prescribing, promoting physical activity. We've a project looking at young adults with type 1 diabetes, and we've just started to work with an international group called the International Behavioural Trials Network to make sure that the work we're doing is currently to the fore in this area. If you're interested in the group, I'd encourage you to have a look at our website. We do offer regular workshops and have a series of ongoing seminars. So I want to acknowledge all the members of the Health Behaviour Change Research Group and collaborators who have worked on in this research. And finally, I suppose just to comment that I think Orla Hardiman earlier said that her research career has, in large part, she can give full credit to the HRB for it, and I certainly would like to acknowledge the significant support of the HRB to not just me, but to behavioural science and to a range of different disciplines. So thank you very much for your attention.